Welcome to the deep dive. Today, we're tackling something many clinicians see frequently, but which can still be, well, quite perplexing. Pain between the shoulder blades. Interscapular pain.
Indeed. It's common.
Exactly, but the origins, they can range from simple muscle aches right through to, well, life-threatening emergencies. It makes diagnosis a real challenge, particularly for our orthopedic and neurosurgical colleagues out there.
Absolutely. Precision is key.
Which is why we're so pleased to have you here today with your deep expertise in orthopedics and spine surgery to help us navigate this. So let's start with the basics. This interscapular pain, it's known for having so many different causes. But maybe we could begin with the anatomy. Why is this particular region such a hot spot for varied pain presentations?
Right. Well, the interscapular area, it's really a crucial junction. You've got the thoracic spine, T1 to T12, and the intervertebral discs acting as shock absorbers, providing movement.
Yep.
That's the core structure. But then you have this dense network of muscles layered over it. Primarily, the trapezius and the rhomboids, major and minor, they're vital for stabilizing the scapulae and moving the spine.
The big movers.
Exactly. And then supporting players like levator scapulae, latissimus dorsi. And critically, weaving through all this are the spinal nerves exiting between the vertebrae. They handle motor control, sensation, even autonomic functions. So any nerve irritation or compression there.
Can radiate pain.
Precisely. It explains those sometimes confusing pain patterns we encounter.
That really paints a picture of the complexity. Now, obviously, muscular strains are common, poor posture, lifting injuries. But what about the less obvious musculoskeletal causes, the ones that might not immediately spring to mind?
That's a great point. Beyond the straightforward strains, from slouching or sleeping awkwardly, we definitely see a lot linked to sustained poor posture. Think desk jobs, smartphone use, that text neck posture.
Right, the modern hazards.
Indeed. And repetitive movements, maybe overhead work like in dentistry or certain sports, leading to chronic overuse. But also, and this is often missed, issues originating in the shoulder itself.
Ah, referred pain again?
Yes. Shoulder instability, rotator cuff problems, even AC joint dislocations can refer pain straight to the area between the shoulder blades. It can really throw you off the scent.
And deeper still, within the spine itself.
While thoracic herniated discs, while less common perhaps than cervical or lumbar ones, can certainly cause thoracic radiculopathy, nerve root irritation, leading to pain, tingling, sometimes weakness.
Okay.
Then there are vertebral fractures, especially compression fractures in the thoracic spine, often in older patients with osteoporosis. We also need to consider things like scoliosis, osteoarthritis affecting the facet joints, or spinal stenosis.
So long list already.
It is. And then you have more localized syndromes. Myofascial pain syndrome with its trigger points, snapping scapula, levator scapula syndrome, and this broader condition some call cervico-thoracoscapular syndrome or T4 syndrome. It just shows how many different mechanical things can go wrong there.
It really highlights the need for a very thorough musculoskeletal exam. But let's pivot slightly. What about those alarming cases where the pain isn't musculoskeletal, where it's a sign of something much more serious coming from internal organs? What are the absolute red flags we must not miss?
This is where clinical vigilance is, well, paramount. The key thing I always stress is looking for pain that seems disproportionate to any apparent mechanical cause or has unusual accompanying symptoms. Think visceral referred pain.
Okay, like cardiac issues.
Exactly. Heart attack is a big one, especially in women where it might present primarily as interscapular pain, maybe with some subtle chest discomfort, shortness of breath, feeling lightheaded, or excessive sweating.
So not always the classic chest clutching scenario.
Not always, no. Then there's aortic dissection, that sudden tearing pain, often radiating straight to the back. And pulmonary embolism, a clot in the lung, usually presents acutely with sharp pain, shortness of breath, maybe some leg swelling or coughing up blood. The suddenness and the systemic signs are key giveaways.
And gastrointestinal causes?
Yes, acid reflux can cause a burning sensation back there, sometimes made worse by NSAIDs, actually. Gallbladder problems, infection, or stones often radiate pain from the upper right abdomen around to the back, frequently with nausea.
Anything else systemic?
Shingles, of course, with its characteristic rash along a nerve path. And unfortunately, certain cancers can refer pain there: lung, lymphoma, liver, esophageal, mesothelioma, or bone metastases. The real clue is often that disconnected pain severity doesn't match the patient's activity level or just doesn't respond to usual musculoskeletal treatments.
That distinction about disproportionate pain is so critical. So understanding the cause is everything.
Mhm.
When you're assessing someone, what key risk factors are you really homing in on, perhaps especially those linked to our modern lifestyles?
It's a mix, really. We still look at the classic individual factors. Age certainly plays a role,
Mm.
with degenerative changes more likely in middle-aged and older adults. Gender, too, there's data suggesting a higher incidence in females, perhaps around 25% versus 17% in males, which is quite interesting.
That's a significant
It
difference.
is. And of course, any pre-existing issues like reduced mobility, muscle weakness, or previous injuries. But the lifestyle factors are increasingly prominent.
Like the posture issue we mentioned.
Exactly. Prolonged poor posture from desk work, but also very much from smartphone use now. Improper lifting, repetitive overhead stuff, contact sports, those remain relevant. But what's perhaps newer is the impact of increasingly sedentary lifestyles.
Leading to deconditioning.
Precisely. Muscles get weaker, imbalances develop, making the interscapular area more vulnerable. And we shouldn't overlook socioeconomic factors. Either they can impact activity levels, access to health care, and therefore both the risk and the management.
It really brings it up to date. So, given this incredibly broad range of possibilities, how do you approach diagnosis systematically? From that first conversation through to potentially needing advanced imaging.
Systematically is the right word. It has to start with a really thorough patient history. You need to pin down the onset, duration, intensity, what makes it better or worse, any specific triggers, is it acute, is it chronic? That conversation is often the most revealing part.
Listening carefully.
Absolutely. Then comes the physical examination, looking closely at the upper back and shoulder, any obvious injury, tenderness, swelling, limitations in movement. We'll use specific orthopedic tests, maybe a scarf test or painful arc test. Careful palpation of the thoracic spine is crucial, and testing motor strength and sensation is key to check for nerve involvement.
And when do you decide imaging is needed?
Based on those findings, X-rays are often the first step for looking at bones fractures, arthritis. If we need more detail, perhaps for spinal stenosis or a suspected tumor, a CT scan gives great bony detail.
And for soft tissues,
Then MRI is the gold standard, especially for things like herniated discs or ligament problems. If we strongly suspect nerve issues, an EMG, electromyography, can assess nerve and muscle function directly.
and if it looks like referred pain,
Then we pivot quickly. ECG for suspected cardiac issues, maybe esophageal studies for reflux. It's really about following the clinical clues logically.
okay, let's dive into something really specific and relevant for our surgical audience. We hear about it anecdotally quite a lot. Postoperative interscapular pain after an anterior cervical discectomy and fusion, ACDF. It seems common, but what does the evidence actually tell us about this?
Yes, this is a really interesting one. It's definitely something spine surgeons encounter frequently, yet, as you say, it's been rather underreported in the literature until more recently.
So it is common.
It appears so.
Mhm.
One recent retrospective study looked at 31 patients after ACDF for a cervical disc herniation and found that, remarkably, 54.8% experienced this specific post-op pain.
Wow, over half.
Indeed. And clinically, it tends to appear quite soon after surgery, typically within 48 to 72 hours. In that study, some cases were even within 24 hours. The key feature is that this pain usually wasn't there before the operation.
Right, it's a new symptom post-surgery.
Exactly. And while it can certainly interfere with early recovery and comfort, the good news is that it usually resolves spontaneously, typically within about 2 months. But it's often missed in standard follow-up because typical cervical spine questionnaires don't specifically ask about interscapular pain.
So a prevalent, temporary, but often overlooked issue. Did that study manage to figure out why it happens? What's the likely cause?
Yes, and this is the really crucial part. The researchers hypothesized that using prosthetic implants during the ACDF that were essentially too tall for the space could lead to overdistraction of the zygapophyseal joints, the ZAJ or facet joints.
Overstretching the joints at the back of the neck.
Precisely. And their multivariate analysis pointed quite clearly to this. A post-operative increase in the distance between the rims of these ZAJ joints was the only independent factor significantly linked to developing this post-op interscapular pain. The p-value was 0.02, which is statistically significant.
And they ruled out other factors?
They did. Things like age, gender, smoking, diabetes, pre-op pain levels, symptom duration, even changes in overall disc height or cervical curve. None of these showed an independent link. It really zeroed in on that ZAJ over-distraction.
So what's the thinking behind how that causes pain between the shoulder blades?
The thinking is that overstretching the capsule of these synovial ZAJ joints stimulates the pain-sensing nerve fibers within them, the nociceptors. This also explains why the pain often doesn't respond well to standard painkillers or NSAIDs. It's fundamentally mechanical irritation.
Right, not primarily inflammatory.
Exactly.
Okay.
And the fact that it tends to resolve on its own within weeks suggests the body gradually accommodates this distraction or adjacent levels compensate. It's a neat biomechanical explanation.
This feels like a really actionable finding for surgeons. If ZAJ over-distraction is the main culprit, what does this mean practically for surgical technique and patient management?
Well, the most direct implication is the critical importance of accurate implant sizing. Surgeons really need to aim for an implant that restores height appropriately without causing excessive segmental distraction and that subsequent stretching of the posterior ZAJ joints.
So choose the right size cage or implant.
Essentially, yes. Proper sizing could potentially reduce this quite common, albeit temporary complication quite significantly. Now, detecting a few millimeters of overdistraction intraoperatively with fluoroscopy alone can be tricky.
True.
This is perhaps where intraoperative CT scanning could be particularly valuable. It offers much better precision to actually verify the implant fit and the degree of ZAJ distraction in real time.
Preventing the problem before it starts.
Ideally, yes. And understanding this mechanism helps us manage patients better postoperatively, too. It might refine rehab protocols, perhaps avoid unnecessary medications that won't work anyway, and ultimately improve patient satisfaction and speed up recovery.
It's a fascinating finding. But given it stems from, initially, retrospective data, what are the limitations we need to keep in mind, and what's the next step for research in this area?
You're right to ask about limitations. It being retrospective is the main one. It limits the strength of the cause and effect conclusion. The sample size was also relatively small from a single center, so we need to be cautious about generalizing.
And how pain was measured?
Yes, it was just presence or absence, not severity, which is a bit crude. Also, some potentially relevant patient data like BMI or detailed smoking habits weren't available. And importantly, they didn't analyze segmental lordosis changes, which could also play a role in the biomechanics. So it's a very strong signal, but needs confirmation.
So what's needed next?
The clear next step is higher quality research. We really need well-designed prospective studies, ideally multicenter, with larger patient numbers and longer follow-up periods to properly validate these findings.
To confirm the link definitively.
Exactly. And beyond just confirming the ZAJ link, future research should probably look more broadly at the biomechanical effects of things like overcorrecting the segmental curve or over-distraction on the overall alignment and function of the cervical spine long-term.
Moving towards optimizing the entire surgical approach.
Precisely.
Okay, bringing it back to the broader picture now. While that post-ACDF pain is a specific surgical issue, for the general population experiencing interscapular pain, what are the go-to non-surgical treatments and preventative tips you'd advise our colleagues to emphasize?
Right. For most cases, non-surgical management is the mainstay. Medication-wise, we often start with over-the-counter NSAIDs for inflammation. Sometimes short courses of oral steroids or muscle relaxants can help in acute phases. And if there's a nerve pain component, certain antidepressants can be quite effective.
But therapy is key.
Physical therapy is absolutely central. Tailored exercises to strengthen the scapular stabilizers and spinal support muscles, stretching tight muscles, improving posture and flexibility, things like shoulder blade squeezes, cat-cow stretches, arm circles, doorway chest stretches, neck stretches, simple but effective.
And lifestyle changes.
Hugely important, often the most sustainable solution. Ergonomic adjustments at work, desk setup, chair height, taking regular breaks from sitting, using proper lifting techniques. Applying heat or ice for temporary relief can be soothing. Massage therapy can also help release muscle tension.
And prevention.
Prevention really boils down to maintaining good posture consciously, avoiding prolonged static positions, warming up properly before exercise, lifting correctly, and generally adopting a healthy lifestyle. Good nutrition, adequate sleep, managing stress, and definitely advising smoking cessation as it impacts tissue healing.
And surgery for general interscapular pain, when does that come into play?
It's generally reserved for those cases with persistent severe pain that just hasn't responded to a good trial of conservative measures, and where there's a clear structural problem identified on imaging, maybe severe arthritis, a fracture, or perhaps scar tissue that needs addressing surgically. It's definitely not a first-line option for most.
This has been a really comprehensive journey through interscapular pain, from the everyday muscle ache, through serious red flags, right down to specific post-surgical nuances like the ZAJ overdistraction after ACDF. It really underscores the need for meticulous diagnosis and understanding the underlying mechanisms for truly effective care.
Absolutely. It's a common complaint with uncommon complexity sometimes.
It certainly seems that while this postoperative pain might be temporary, its impact on quality of life shouldn't be underestimated. Hopefully, this discussion encourages our surgical colleagues to think even more carefully about implant sizing. We certainly hope you listening have found this deep dive valuable. If you have gained insights today, please do consider rating and sharing the show. It helps us reach more colleagues like you.
And perhaps a final thought to consider. How often might other subtle postoperative discomforts be overlooked, impacting patient satisfaction, when a deeper dive into the biomechanics might reveal a relatively straightforward mechanical cause? Are there common post-surgical complaints in your own area of practice that might warrant a similar biomechanical investigation?
A really thought-provoking question to end on. Thank you so much for sharing your expertise with us today, and thank you all for joining us on the deep dive. Until next time, keep digging deeper.